Thank you.
Thank you so much. So thank you for being here with us today. My name is Reid Mergler, and I am a PGY3 at Tufts Psychiatry.
And I'm Amanda Koire. I'm an MD PhD. I'm a PGY2 at Brigham and Women's Hospital Psychiatry.
So we will be presenting today on trauma-informed care in the perinatal period. The objectives of today's talk are to, 1, discuss the prevalence and epidemiology of birth trauma. 2, to learn how to screen for birth trauma. 3, to review the E's, the R's, and the 6 key tenets of trauma-informed care. And 4, to discuss how it applies to the perinatal period.
And hopefully we'll leave some time for questions and discussion at the end. So the first topic we want to discuss today is birth trauma as a concept. What is birth trauma? Here we'll be talking about birth trauma as a shorthand for symptoms of PTSD after childbirth. This is more common, I think, than people really realized. The estimates for how frequent this is somewhere between 5 and 9% of women experiencing PTSD following childbirth, specifically related to the experience of childbirth. Up to 1 in 4 women, however, can have 1 or more symptoms of PTSD in the postpartum period, even if they don't meet full criteria for a DSM-5 diagnosis. Birth trauma and childbirth-related PTSD was really only recognized as a construct in the 1990s, and research on this topic has really just been over the last 15 years or so. Previously, it was considered too common an event, the experience of childbirth, for it to be meaningfully traumatic. And I think we have come to realize over time that that isn't the case. PTSD from childbirth can present in a number of different ways. So in addition to flashbacks to the event, nightmares related to their childbirth experience, hypervigilance and anxiety, as you might see in PTSD in other contexts, one of the ways in which PTSD from childbirth can be different is through how avoidance presents. And avoidance can present as limiting postnatal care engagement because women are uncomfortable going back to the hospital where they delivered, if maybe that's where they're getting their postpartum OB appointments or their pediatric appointments for their new baby. It can result in isolating from other women with babies and avoiding other women with infants, which also can put them at risk for postpartum depression. And there is a strong link between PTSD related childbirth and postpartum depression. This can also result in challenges bonding with the baby, who is, of course, a reminder of that childbirth experience intrinsically. And it can lead to them feeling very deeply anxious or conflicted about a future pregnancy, or on the other hand, maybe determined to prevent a future pregnancy and avoid going through that same experience again. As you can imagine, this may also lead, then to sexual dysfunction or an impaired relationship with their partner if they are avoiding having, sexual intimacy because of, being uncomfortable with the idea of a future pregnancy. So this is an opportunity for us to kind of shout out in the chat or off mute, if that's a possibility, depending on how this presentation is structured, to talk about some risk factors for birth trauma or childbirth-related PTSD, because there are many. Let's see. Oh, let's see. Aha, I'm seeing things in the chat. All right. Anyone have ideas? Some risk factors for birth trauma? All right, well, I will just talk. There's quite a laundry list and I won't read it all. Oh, yes, thank you, Annie. C-section, that is one, especially if it was an emergency C-section, unplanned. A lot of times those urgent or emergency sections mean that, they thought everything was fine and then all of a sudden an entire room of people descends on them and says, you're getting surgery you didn't expect. That's traumatic, and they may wonder if their life or the baby's life is in danger, and it may well be. So
I imagine, I don't know if we're supposed to, are we just supposed to say it? I would imagine just kind of like a general sense of loss of control over that whole process, which happens a lot because having a baby is crazy. So yeah, that like loss of autonomy, loss of control.
Absolutely. And I feel like feelings of loss of control is this, big concept that often does get overlooked because, there are some very specific things like NICU stays, physical injuries, but even just the feeling of loss of control, which is very subjective, is a huge risk factor. If they came in with a very structured birth plan of exactly what they wanted, and then that all got thrown out the window, that can be a risk for trauma, even if a different person subjectively might say, well, that sounded all fine to me. They may experience that as very traumatic. Another thing to keep in mind is that previous trauma, especially sexual assault, is a risk factor for birth trauma or childbirth-related PTSD, in addition to factors of the labor and delivery itself. One common theme you'll see with some of these examples is if there was a risk, to the mother's life or the baby's life in the process, that is typically going to be a risk factor.
I did see Eliza raised her hand as.
Yeah, I was just going to say that like poor support, whether it's the partner or just lack of support, if the woman is alone giving birth, these are big problems and risk for trauma.
Absolutely. And I would definitely include that also in the poor postnatal care. That's not necessarily, the nurses or the OBs, that's who is taking care of you after birth. Is it your partner? Who's there with you? Who's there supporting you? Absolutely. And we'll talk about that a little bit more too, in terms of how COVID has affected rates of birth trauma. All right. So just for the sake of time, moving to the next slide. So the COVID pandemic has also affected birth trauma and rates of birth trauma in some ways that you can imagine. At this point, we're like years into the pandemic. I will not be one to say that it is over, but especially at the beginning of the pandemic, when we really nobody really knew what was happening, and all of the rules and restrictions were pretty severe in terms of infection control. About 2 in 3 women, so the vast majority, reported a very high level of stress and fear about entering the hospital. They were very worried that they would contract COVID if they went to the hospital to deliver, and nobody was really sure what that would then mean. There wasn't a lot of data yet. And most women around that time did experience unexpected birth plan changes. Most commonly, it was that support people were not permitted to attend the baby's delivery. That happened to about half of people, what they were really worried about. And that was experienced by most people as a pretty traumatic experience. So we're still going to be seeing the effects of that lingering, even as some of those rules and restrictions have loosened over time. So now that we've kind of all have a sense of what birth trauma is, the next aspect is, how do we screen for it? How do we incorporate that into our clinical practice for those of us who do practice clinically? So the City Birth Trauma Scale is a specific measure that has been created to assess birth trauma. It's a 31-item self-report scale developed by the University of London, well validated, that asks about symptoms over the past week of general and birth-related PTSD symptoms. They also have a partner screener for the partners of women who may also have been traumatized, because recall from our DSM that you don't need to have been the one to personally experience the trauma. Having been witness to that is also considered a qualifying event. And the partners do often experience traumatic symptoms as well. And if you're uncomfortable using a newer type of scale specific for birth trauma, you can always use the PCL-5 for PTSD symptoms. The most important thing is to be aware that this could even be an issue, and to ask. So that's a good place to start, just asking about what their experience in childbirth was and how they feel about it now.
So as Amanda explained, there's a very high prevalence of trauma, and it is critical to consider trauma-informed care when working with our patients and our clients. You may ask, what is trauma-informed care? And it is an approach in the human service field that assumes that an individual is more likely than not to have a history of trauma. The overarching goal of TIC is to shift the conversation from what is wrong with you to what has happened to you. And more specifically, it seeks to acknowledge the past experiences of individuals in a way that supports healing and avoids re-traumatization. It values subjectivity as an integral part in the healing process, and it ensures safety and respect and enhances healthcare equity. This is really shocking to some providers, but you do not need to delve into the details of one's past experience when providing trauma-informed care. And applied to birth trauma, it is important to not actually debrief immediately following a delivery or in the postpartum period, like 1 week out, because this can be re-traumatizing and difficult for patients to go into. When I think of trauma, I like to think of the 3 E's, and this includes events, experiences, and the effects. So for the event, it could be a traumatic delivery due to a placental abruption or an emergency C-section, and the experience is individualized. It is based on one's perception of what a childbirth can look like. And the effects are long-lasting, and sometimes are seen in the postpartum period immediately, and sometimes are seen years later during the next delivery or during prenatal care. And in trauma-informed care, the effects are often noticed first. Sometimes providers do not always learn about the event or the experience via disclosure. And the adverse effects include an individual's inability to cope with the normal stresses and strains of daily living, to regulate their own behavior, and to control the expression of emotions. This is seen most often on a postpartum unit when somebody is labeled the difficult patient or the complicated patient. And this is often due to the person's history of trauma and the fact that they have that difficulty with self-regulation and coping skills. And they might not have that support from the partner that Amanda talked about. So the 4 R's of practicing trauma-informed care include realizing, recognizing, responding, and resisting. So 1 is realizing the widespread impact of trauma. Half of American women have experienced a traumatic event throughout their lifetime. And so thus, when we were taking care of women, we have to assume that someone has a history of trauma. It's important to recognize signs and symptoms of trauma, not only in patients and those families, but in the staff and the clinical team. So the nurses, the residents, the doctors, the PAs, and the like, everyone may have a history of trauma, and this can affect their clinical care. And to recognize and to respond to this is really important to support the well-being of the clinical team. We also have to respond by fully integrating knowledge about trauma into policies, procedures, and practices. And this can be on the institutional level as well as local and national levels as well. And lastly, it is to resist re-traumatization. And as I stated before, be avoiding that immediate debriefing, as this can often then have a negative impact on somebody's healing and then lead to consequences down the line in their next pregnancy. So the 6 principles of trauma-informed care include 1, safety, 2, trustworthiness and transparency, 3, peer support and mutual self-help, 4, collaboration and mutuality, 5, empowerment, voice, and choice, and 6, consideration of cultural, historical, and gender issues. To apply this to the perinatal period, I developed a project at Tufts to collaborate with my OBGYN and pediatric colleagues. And it was really great to see how, with that mutual goal of providing trauma-informed care, we were able to provide patients with this collaborative care approach. We led small groups and have monthly TIC rounds to discuss the quote difficult patients and think about how we can do better next time. Trustworthiness and transparency is also key. And to develop that sense of trust with the patient and have that therapeutic alliance can keep them coming back to a provider and engaging in prenatal care the next time.
So another way in which this can be relevant is through peer support. Having an infant who requires NICU care is a huge risk factor for birth trauma and birth-related PTSD. And there are often peer support groups for that you can help link your patients to. However, keep in mind that sometimes those groups can be triggering also, or provoke feelings of avoidance in patients, and offering or making available individual therapy may be more appropriate depending on where they're at that moment. When we look at empowerment, voice and choice, and collaboration, it's important to keep in mind that if and when that patient becomes pregnant again, they may have a deep desire to undo the trauma in some way. You know, maybe somebody who had a very complicated vaginal delivery really wants an elective C-section this time that otherwise might not be medically indicated, or on the other hand, wants to avoid hospitals altogether and have a home birth or free birth. It's really important to know, even if this patient may seem like they're being perceived as difficult or not following medical advice in some way, that usually those deep desires are coming from somewhere and may be rooted in their trauma. And to empower them as much as possible is really important in their recovery. And then for sake of time, we won't elaborate further on some of these other ones. If there's any time remaining, we'll allow for a question or two. Thank you so much.
Yes, I don't believe we have any questions. Oh wait, here we do have a question. Yep.
I had one
So
in the
we
chat
have-
just about if the immediate debrief is not recommended, what could be done in sort of the immediate aftermath to be supportive to someone who's just undergone a birth trauma?
So one thing I would recommend is that linking them to services that will provide that support and structure over the long term. So it's more that if they've just had this really extensive, say medical trauma, not to be in a position where they're having to list every single thing that happened to a number of different people, but instead being like, I'm recognizing right now, this is someone who should have a therapy referral maybe out of the gate, and be able to go through that just the one time with their therapist that they're establishing with in the long term would be one example. So you just don't want them to have to, explain their trauma and over to a lot of different people.
Great, thank you so much.
Thank you. And then I see Eliza Hoffman has her hand raised. I'm so sorry we haven't.
Oh, no, sorry. I just never took it down.
Oh, okay.
I'm good.
Thank you. Okay. Thank you so much for joining us today. We really thank all the participation in the Zoom room.
Feel free to find us through the WOVA app and ask questions, or reach out to us there if you have other questions that arise.
Yeah, definitely reach out via WHOVA. It makes it pretty easy to find our speakers and interact directly. Actually, there's one more question. How can providers help prepare patients who have a history of trauma for birth?
So I think it's important to kind of establish that rapport early on in the prenatal course to have them trust you and trust the process, and not to be, not to have them too alarmed by all the different things that can go wrong, but have them have an understanding that that can happen and that the providers are doing their best to support the patient.
I think that a lot of times, there is a lot of emphasis on people creating these birth plans of exactly all the things they want. And I think discussing those from the context of, these are all the things that we hope to have happen. But, that no specific outcome can be guaranteed is helpful. There are a lot of things that come up, especially for first-time parents that, if you've been in the field for a long time, you take for granted, but is absolutely new news to a new parent. And I think that when you can really walk someone through what to expect, do the hospital tours ahead of time. Don't tell them when they're 38 weeks that actually it might not be your OB who delivers. Like to an OB, like, oh, of course, like that's just how things work with hospital coverage. But the more that a patient knows about what they can expect or not expect in the delivery, the better prepared they can be to be unprepared in a way.
All right, I think that's all we have for time. So that way we can give people the chance to switch over to the next session. But yes, definitely reach out to Reid and Amanda with any additional questions. Thank you so much for your session. This is great.
Thank you.